in case you have a time. It's close to Rahim Yar Khan. It's a very beautiful mosque, a lot of history to that. Okay, let's start with the presentation. So the incidence and prevalence of peripheral neuropathy increases with age. So after the age of 50, it's almost 8%. And as it goes more, like you can see, more than 80%, 80-year-old people, it's 30% of the patients do have definite polyneuropathy. But more importantly, which is a kind of a dilemma for the neurologist and neuromuscular subspecialist, is there are more than 200 etiologies of peripheral neuropathy. So despite the fact you can diagnose there's a neuropathy, you do know what type of neuropathy it is, but when it comes to why a patient had it, it's a whole list of investigations. So I'm going to discuss some personal experience with that. And actually, I used to do that for my colleagues in the US as well, who are not neuromuscular trained. Because we also come across quite oftenly with incidental abnormalities on workup. And many times we get drifted away by the idea that that may be the reason this is the patient, particular patient is having polyneuropathy. But it has been noted in a study that almost patients who were undiagnosed having distal symmetric peripheral neuropathy, almost 60% of them were on workup. They were undiagnosed despite everything. And when later on they were evaluated in tertiary care setup, they just up to 10% were diagnosed more. So 50% of the patients were still left behind, undiagnosed for the etiological reason for the neuropathy. So this is one very nice article written by Peter Dick, and he actually wrote down 10 points to evaluate or test 10 steps to evaluate peripheral neuropathy. I didn't took those 10 steps, but I'll say when we come across a patient, we try to see the pattern of the disease or the pattern of the neuropathy. Is it a neuropathy? Is it a flexopathy? If it is a flexopathy, what type of flexopathy it is? Because if the brachial flexopathy could be acquired, it could be genetic as well. Radiculopathy, what type of radiculopathy it is? We need to recognize those patterns. Multiple mononeuropathy, or more commonly we know this as mononeuritis multiplex. So there's a total different workup involved when we come across it. I think the first step should be recognizing that there is neuropathy. The next step would be what's the pattern of that neuropathy is, and then further workup can be done accordingly. And it could be symmetric, asymmetric, and I'll discuss more with respect to these different types. Oh yeah, keep getting these pop-up screens. Okay. So the clinical approach, as we all neurologists believe, the most important thing in neurology is history. If you don't know what's going on, go back to the history again. And my mentors used to say, history, 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 before we actually go to examination. So we really need to be sure what we are coming across. And then we confirm our history findings on examination, and the ancillary test can be done to support the suspicion or to see the pattern of involvement. Laboratory testing can be done, and there is a whole list of testing which can be done to tease out the etiology. The next step in management is supportive and therapeutic. So we all know that most of the time what we come across is supportive care, because most of the neuropathies are progressive. We try to do some medications or try to improve, but many times it's just the supportive care involved. But with respect to that, we need to counsel our patients, because what I came across, patients go to one physician, then to the next physician, thinking that their neuropathy may improve. But we need to counsel them on very first time that we may be able to help them with the symptoms, but not exactly with the pathology or the progression of the disease. The next step is physical therapy, which I personally feel that we also need to guide at the very first step, that the patients need to look forward to physiotherapy or continue exercise and healthy activities to keep on doing what they are doing, because it's for general well-being and also for the progression of the neuropathy, it's very helpful. And the follow-up evaluations should be done. If the patients keep on skipping physicians, it really becomes harder to keep track of the progression of the disease. In terms of history, as I already mentioned, the pattern of involvement is very important. Also, sometimes we, as neurologists, say, is it positive symptoms or negative symptoms? And we try to see based on that, because in genetic disorders, it's predominantly the negative symptoms. Okay, and when it comes to the acquired pathologies, positive symptoms, both motor and sensories could be there. Time course of the disease is very important, especially when we try to squeeze the type of neuropathy in a particular diagnosis. The time course comes in, and we have to put those patients according to the time course. Is it an AIDP or say CIDP or some other type? Risk factor assessment is very important. If patient has received chemotherapy, has previous history of tumor, some hematological malignancy is very important, or knowing the comorbid conditions is very helpful in diagnosing these patients. Examination, again, we have to pick up the pattern as we discussed, and in pattern, there could be cranial nerve involvement. We really need to make sure, because not all neuropathies have cranial nerve involvement, especially in the start. Then comes the confirmation of the weakness and pattern of weakness, deep tendon reflexes, sensory involvement, and if we are suspecting small fiber involvement, then we should check for autonomic dysfunction by checking orthostatic blood pressure. And then comes the systemic examination, because it has happened with me many times that patients come in for neuropathy assessment and turn out to have some other systemic disorder going on, like POEMS or something else. So when we say patient has neuropathy, there is a general consensus statement about these patients that these patients should have at least a distal symmetric sensory symptoms or distal symmetric sensory loss on examination, beside a diminished or ankle reflexes. So two of these should be there to say this patient has definite neuropathy before we go to further testing. I would like to elaborate a little bit with respect to when we say neuropathy, or what's the difference between neuronopathy. So the neuropathy, as we already discussed, it could be distal, it could be a proximal involvement, it could be patchy, but in neuronopathy, it's mainly the nerve cell involvement. So it could be anterior horn cell in case of motor neuropathy, it could be dorsal root ganglion in case of sensory neuronopathy, and that pattern can give us the idea about the etiological diagnosis of these patients. And your workup can be more defined, and you don't need to do a lot of investigation to get to the diagnosis. When we try to put the pattern of the neuropathy, we look for, is it axonal, demyelinating, but many times we come across a mixed pattern, so it becomes a challenge. But as a neurologist, as a neuromuscular subspecialist, what we should try to do, or what we try to do in general, is to see what's the predominant pattern is it. If there's a predominant axonal pattern, is it a predominant demyelinating pattern? And then we do additional testing to make sure that does our further testing support the idea. Then we have to see if it's symmetric or asymmetric. Again, if it's a mononeuritis multiplex, it's going to be most commonly asymmetric presentation. Then we look for that workup in those patients. Again, length dependent or non-length dependent, which I'm going to elaborate a little bit more in my further slides. Again, we have to see it's a large fiber involvement, small fiber involvement, which is autonomic fibers, or it's a mixed involvement, which is what we see most commonly in diabetes mellitus. Okay, so when it comes to length-dependent neuropathy, the demyelinating polyneuropathy or axonal polyneuropathy, again, it could be both acquired and hereditary in both cases. But what we have to do is to pick up the pattern, try to see is it predominantly motor or sensory, or there could be hereditary component to that. In case of non-length dependent, as I already mentioned, it could be neuronopathy, which initially can present, especially in case of sensory neuronopathy, as a distal symmetric sensory involvement, but with the progression of time, it turned out to be non-length dependent. And there are further testing which can be done to prove that point. Multifocal neuropathy, like multiple motor mononeuropathy, can be the case. Polyradiculopathy, polyradicular neuropathy. Again, these are all different patterns which help us define the etiology of the disease, because it's easy to pick the neuropathy, but putting it in a box is the key. Then comes there is a new terminology which some residents may find difficult, is nodopathy. And it's mainly the ion channel disruption. And what has been noted, especially in case of acute motor axonal polyneuropathy, that these patients, after immunoglobulin or therapy, they improve pretty quickly. And when they improve quickly, it cannot happen in axonal neuropathy. So the hypothesis is with respect to ion channel disruption. So as soon as the disruption is improved, the conduction velocity and the amplitude of these patients improve. And this pattern has been seen in beside AMAN, it has been seen in CIDP, multifocal motor neuropathy, drugs, thiamine deficiency, and ischemic monomelic neuropathy. As I said, this is the key part of this presentation. So it has been noticed that almost 74 to 82% of the patients, we are able to find the etiological diagnosis. But we have to be systematic in that case. So when I say systematic, we need to do some high yield investigations, especially we have to do our blood glucose level, if needed, OGTT. I preferably like to do A1C because many times patients report their blood glucose level is normal or it's pretty borderline. But we all know sometimes the neuropathic clinical findings are there even before the patient is diagnosed with diabetes mellitus. So besides clinical exam, we can do A1C just at the startup to know if there is a possibility of diabetic polyneuropathy, which is the most common type of polyneuropathy. The next comes our metabolic panel, especially if there is a history of systemic disease like renal failure, hepatic failure, complete blood count. I'll say, especially with respect to looking for malignancies, is very helpful. I do a screening ESR-CRP because if we are looking for vasculitic mononeuritis multiplex kind of pattern, this could be the screening test to really say, is this the pattern of the disease and what should we look next? B12 and methylmalonic acid or homocysteine levels. Well, in Pakistan, I don't know if any lab does methylmalonic acid, but I know some labs do homocysteine levels. But it is really helpful because even B12 levels is on the lower side. Homocysteine levels or methylmalonic acid can be high in 5 to 10% of the patient. And that can give us the idea that it is the etiological factor, which is actually playing part in polyneuropathy. The next most important investigation and the high yield investigation is serum protein immunofixation. I came across many times patients after coming back to Pakistan where this test was missed. It was also missed in the US as well, so not an uncommonly missed test. But I'll say, I would like my audience to consider this next time in the initial testing of the polyneuropathy patients. The low yield tests are a thyroid function test. I do that all the time, especially when it's not getting diagnosed, but believe me, rarely it came back positive. And even in that case, was it significant to play the part? I'm not sure about that. Anti-nuclear antibodies, sometimes I does it as a screening test, and it is usually followed by ENA profile looking for autoimmune disorders. Vitamin B6, vitamin E deficiency, especially with respect to patients who are having sensory neuropathy or autonomic dysfunction, I tend to do these tests. Rapid plasma reagent, Lyme serology, I haven't done those in Pakistan, but it was kind of a routine to do those tests, especially when there's concern for infectious neuropathy. HIV testing, I think I should do it more frequently in Pakistan, but in the US, we were doing it quite frequently. I have ordered in some patients heavy metal screen, especially where there was a motor neuropathy and I was not getting a correct diagnosis. So as part of the workup, I have done sometimes heavy metal screen. Folate testing, urine for light chain protein. Again, based on individual patients, it's just a small list. But I'll say it's after the high yield testing, based on the first result of the test, I decide what I have to do next. Then there are some definitive testing. Again, we routinely don't do those tests unless we're really convinced we need to. Genetic testing is something which I'll say comes up in the list, especially when I'm suspecting there is a hereditary neuropathy. Other than that, there could be CSF analysis, nerve biopsy, skin biopsy for small fiber testing. But even in US, nerve biopsy and skin biopsies were rarely done. I did some skin biopsies, but nerve biopsy was not done even single time while I was working over there. CSF analysis, especially when there is concern for demyelinating disorders. Characteristics warranting more testing are acute to subacute onset. So if it's a rapidly progressive disease and it's worsening, we need to do further testing to make sure what's going on. And if we can treat the patient right in time, we can prevent wasting, we can save the patient from disability. And we have to pick if there is a more predominance, non-length dependent pattern, which is more commonly seen in mononeuritis, multiplex, and vasculitis, and those are treatable. Associated dysautonomia, which really narrows down your differential diagnosis to diabetes mellitus, amyloidosis, Fabry's. Associated systemic disease is really helpful, especially when there is a known systemic disease, we need to do further testing because this could be potentially treatable neuropathy. This is a little breakdown of the neuropathy, and as you can see, diabetic polyneuropathy is the most common one. The next common neuropathy is cryptogenic axonal polyneuropathy. And as already mentioned in the start of the presentation, despite whatever you do, a good percentage of these patients, we are not able to find out the etiological diagnosis in these patients. But the next important one is toxic polyneuropathy, and we should be considerate about that, and immune-mediated polyneuropathy, which is a next bigger group of polyneuropathy. So we need to do these testing to make sure what's going on. Hereditary neuropathy, especially if there is a positive family history and patient is less than 40 years of age, we should consider hereditary testing in our patients. And it's available in some places in Pakistan. And you can see the rest of the breakdown, especially with respect to systemic diseases, metabolic disorders, B12 deficiency, and idiopathic small fiber neuropathy. So the summary for my presentation is that we should try to confirm the diagnosis of neuropathy first, try to put it in a box, and then we should try to avoid potentially harmful treatment, which I have seen quite a bit. So we should try to finish our workup as quickly as possible. So we are not referring our patient for high dose steroids for a long period of time without knowing what we are treating. We should look for the natural history and the progression of the symptoms, which is only possible if the patient keeps coming to the one neurologist and there is a communication between the neurologist in case patient is referred to some other higher center. Prevention and management of future complications like falls, trauma related with that, and with medications. Looking for additional pathology in a straightforward case, sometimes we just get drifted away. Okay, this is a standard diabetic polyneuropathy, but there's additionally vitamin B12 deficiency going on, or some other pathological process has been going on. And most importantly, from the patient's satisfaction perspective, and personally with the idea that they shouldn't skip physician, is proper counseling. So if we do that at the first step and give them a fair perspective of what we're gonna do, they will follow what we are asking them for. Thank you very much, everyone, and we will be happy to take questions at the end of the session. And as I said, I will have one slide for my team. So the team members are Sara Khan from Karachi and Dr. Ahmed Wali from Quetta, Dr. Ayesha Khan from Peshawar, and Dr. Ayesha, who is the moderator for today's session from Lahore, Dr. Mazhar Shah from Azad Jammu Kashmir, and Dr. Samad Ishtaq. So these are all your go-to members. So we had this from each province with the idea that if somebody come across any questions, especially consultants, they can approach these particular doctors in their area. And if they are not able to solve that question, it can be further escalated. But we should try to develop a communication system among us. So I really appreciate everyone to know their regional member and approach them with the question. They are all very helpful, and they will all be very happy to support this communication system. And I really appreciate everyone on today's presentation, Dr. Sara Khan and Dr. Sajjad Ali, to take time for being part of our today's presentation. Thank you very much, everyone.
Thank you, Dr. Ehtesham. It was a lovely presentation, and I think it couldn't have been made simpler regarding it's very important topic for the residents. So I think it couldn't have been presented in a simpler way. Meanwhile, while we move on to the second presentation, I would like to welcome Professor Atta Javed, who has also joined us. And then we move on to the second talk of today's session, which is approach to myopathy. Again, a very important topic. For this, I would like to invite Dr. Sara Khan. She's currently working as assistant professor at Aga Khan University Hospital. She's also director of Neurophysiology Lab, and she's also director of Fellowship Neurophysiology and Neurology residency programs. So Dr. Sara Khan is busy with so many things at the moment. Kindly, Dr. Sara, the screen is all yours. You can share your screen now.
Thank you very much, Ayesha. Okay. From the beginning. Okay. Thank you very much, everyone, for joining us on this Saturday. The outline for my presentation is we'll quickly be going through the anatomy of muscles, talk about the spectrum of myopathies that we need to consider when we are thinking of myopathies. I will spend much more time on pattern recognition, clinical pattern recognition, and very, very briefly we'll be going over diagnostic testing and treatment. But today's presentation, I want to focus more on what we can do on the basis of history and exam in diagnosing myopathies. I have no conflicts of interest, and all patient photographs that have been used have been with their approval for educational purposes. So let's go back to med school. And I find these diagrams very helpful whenever we're considering pathologies affecting muscles. The most basic unit of a muscle is the muscle fiber. Multiple muscle fibers combine together to form fascicles. Each muscle fiber is surrounded by a layer of connective tissue, which is the endomysium. Fascicles are surrounded by a connective tissue called perimysium, and a lot of fascicles combine together to form the muscle, where the muscle is surrounded by the connective tissue layer called the epimysium. Whenever we have an attack on the muscle, for example, in the case of inflammatory myopathies, we find inflammatory infiltrate within the endomysium. When we go a little deeper on the very basic structure, the building block of a muscle, it's the sarcomere, which is made by the thick and thin filaments made by actin and myosin. And it is the contraction of the actin and myosin sliding over each other, which ultimately results in contraction of the muscle. So we need these to be functioning properly in order for the muscle to contract. However, for all these myofibrils and this whole structure to actually work, the most important thing is the supporting proteins. There's a huge network of supporting proteins within the muscle, and these muscles, these proteins, if even a single one of them is disrupted, is defective, is absent, will result in weakness of the muscle, because it will affect the structure and the stability of the muscle and affect the functioning of the myofibrils, therefore contraction. The most notorious of this is dystrophin, which we all know, and is affected in DMD, BMD. But what you need to see from here is how interconnected all these proteins are to each other. And therefore, dysfunction of even one of them is going to disrupt the entire chain. So when we, the first thing, when you are thinking about myopathy sitting in your clinic, you have to decide there and then, are you dealing with a hereditary cause or an acquired cause? And that is on the basis of the onset, duration, rate of progression, family history, the clinical features that you're going to see, and then you're going to tune your diagnosis with the tests that you're going to order. When we talk about hereditary myopathies, we are considering congenital myopathies, which are so named according to very specific structural abnormalities that we see in the muscle. Dystrophies, which are named so because of abnormal or deficient proteins. Or metabolic myopathies, which are because of accumulation of metabolites and defective energy generation. When we consider acquired myopathies, we're thinking about inflammatory myopathies, which is usually an external attack on the muscle. And we're talking about toxic or endocrine myopathies, which affect the muscle membrane stability. And this also includes the mitochondrial myopathies. So congenital myopathies, if you just look at this whole list of hereditary myopathies, this is a very brief list of what we're actually considering. If, say, somebody is coming with a long-standing history, with a family history, this is all that needs to go through your mind. Congenital myopathies are, like I already mentioned, are named according to what they look like under the microscope. For example, this is a centronuclear myopathy because all the nuclei are in the center. This is a Nemelin rod myopathy because on a trichrome stain, you see all these collections of Nemelin rods on the muscle. This is fiber disproportion type neuropathy, where all the muscle fibers have different sizes. And then this is central core myopathy, where each muscle fiber has a central core or clearing. Muscular dystrophies, the most common that we know of are DMD and BMD. And then there's a whole group of limb girdle muscular dystrophies, type 1, which is autosomal dominant, type 2, which are autosomal recessive. But there are more than 80 genes in total resulting in dystrophies. And you can see here, again, this is alluding to all the proteins that can be disrupted and all the different types of dystrophies that it can result because of deficiency of even one of these proteins. In acquired causes, we're talking about an external attack on muscles, like we see here, where we have endomysial infiltration of inflammatory cells. This is polymyositis. This here showing perifascicular atrophy is dermatomyositis. And this one is inclusion body myositis with a lot of necrosis. Then in endocrine metabolic disorders, always have to consider basic electrolyte abnormalities, basic endocrine abnormalities, including thyroid, parathyroid, adrenal, or pituitary disorders. Always consider toxic myopathies. I always make it a point to always ask patients if they've been on any medication long-term, whether it be antibiotics, statins, extremely important, steroids, alcohol use, any other drug use, really a long list of medications that can cause myopathy. So this will be the exposure can be fairly clear to you if you have taken a detailed history. So now you've taken your history, and we're going to talk about very specific questions that need to be asked and determined in the history that is going to help you come to a diagnosis. Like Dr. Ehtesham had also mentioned, it's the same for all peripheral nervous system disorders. So be it neuropathies or myopathies, most of them will be localized on the basis of history and exam. This is important for targeting testing and treatment. Only motor symptoms in myopathies, they will only have motor symptoms. And if there's any mention of sensory symptoms, then other disorders need to be thought of. So the key questions, there are 6 key questions I'm going to give you that you need to ask. First thing, is the patient having negative or positive signs and symptoms? Positive symptoms include myalgias or cramps. These can be seen in acquired myopathies, such as your inflammatory myopathies, but can even be seen in metabolic myopathies or mitochondrial disorders. Twitching, myotonia, stiffness, very specific for either things like myotonic dystrophy or channelopathies, which include myotonia congenita or paramyotonia congenita. Is there hypertrophy of the muscles? Does the patient have big muscles? And they usually mention it themselves. Hypertrophy can signify certain kinds of dystrophies, most commonly DMD or BMD, but it can also be seen in myotonia congenita and some other channelopathies. Is there rippling or mounding, or are there early contractures? Early contractures are seen in very specific disorders, for example, Emery-Dreifuss muscular dystrophy or collagen 6 dystrophies. So if somebody has early contractures, it is much more likely to be a dystrophy of a particular kind. On the other hand, negative symptoms include fatigue and weakness, which are very non-specific symptoms. Can't really say anything if somebody tells you those. Exercise intolerance, however, can point towards channelopathies as well as metabolic myopathies. If there is wasting and atrophy, that would point towards a long-standing disorder, much more likely to be a hereditary disorder rather than an acute or subacute acquired disorder. The second question you need to ask is the temporal relationship with this weakness, pain, and stiffness. Is it acute, subacute, or chronic, right? Is it constant or episodic? Is it monophasic, meaning it is very, the moment it started, it is still the same but slowly progressing? Or is it relapsing, that it happened, there was treatment, it improved, and then they had another bout? What is the age of onset? Is it lifelong? Has it been present since birth? And if that is the case, if the baby was hypotonic, had early milestone delay, much more likely to be a congenital myopathy. And are the symptoms progressive or non-progressive? These are all the things that you need to cover in your history. The third question is, what is the distribution of the weakness or stiffness? Most commonly, the distribution they're going to give you is of proximal arms and legs. And the question in this case is, do you have difficulty getting up from the floor? Do you have difficulty climbing stairs? Do you have difficulty getting up from a chair? Difficulty washing your hair, opening cupboards? But it is very important also to ask about distal limb weakness. And sometimes earlier on, and we will discuss this, earlier on, they actually don't have any of these weakness related to proximal muscles. What they do have is loss of grip, right? So it's important to ask, did you get foot drop earlier on? Would you start tripping? शुरू से आप trip होना शुरू करते थे earlier on, या चाबी घुमाने में प्रॉब्लम होती थी, बोतल खोलने में, निवाला बनाने में? अगर ये सारी चीजें earlier on हुई हैं, तो this is a distal predominant myopathy or a distal predominant process. Sometimes it can start proximal and distal together rather than having a gradient. Sometimes they can have isolated neck weakness. They can have pharyngeal weakness, which would include diplopia, ptosis, and swallowing difficulties. Or they ask them if they have atrophy or hypertrophy. Question 4, are there triggering events? If somebody is having episodic weakness, what is the trigger? Does it happen during or immediately after exercise? Does it happen after brief, prolonged exercise? Now, this is very important, especially if it's in, we're considering metabolic myopathies. So brief, usually glycogen storage diseases mein hota hai, or weakness or muscle cramps or pain after a very prolonged exercise is usually lipid storage disorders or something like carnitine, CPT type 1 and type 2 deficiency. Okay, so just by you have to exactly ask के exercise के कितने मिनट बाद आपको problem शुरू होती है. Does it happen after exercise which is followed by rest? And for example, a simple example most common is of McArdle's disease or myophosphorylase deficiency, where they have pain during exercise, then they sit down, rest, and when they resume the exercise, that there is no pain. And that is called the second wind phenomena. So very important, especially if the weakness is episodic, to incite that in your history. Is the weakness triggered by a carbohydrate meal, which will be seen in your channelopathies, such as hypo or hyperkalemic periodic paralysis? Is it relieved by exercise? Was it triggered after you started a certain drug or medication? And is it related to temperature? For example, certain myotonias are worsened with cold temperatures. Question number 5, is there a family history? And if so, try to map out whether it's X-linked, autosomal dominant, autosomal recessive, or mitochondrial with maternal transmission. Question 6, any other associate features? Go through the entire review of systems. कि अगर you know, for example, baldness है, तो आप you think about myotonic dystrophy. If somebody has cardiac involvement, so cardiac involvement is in a whole list of limb girdle muscular dystrophies. It is seen in dystrophinopathies, your DMD, BMD. Okay? It can be seen in channelopathies. They can have cardiac conduction defects. So again, a detailed history is important. Lung involvement. If somebody has acute weakness, acute myalgias, and associated with that, they have shortness of breath, they may have associated interstitial lung disease or anti-Jo1 antibodies, which is causing both the lung involvement as well as the muscle involvement. Similarly, a lot of limb girdle muscular dystrophies have breathing involvement of the breathing muscles very early on. For example, LGMD2I. So the whole list of skeletal contractures, deformities, neuropathy, GI symptoms, you have to take a full review of systems which can help you narrow down your differential. Now, this is the big table that we go by in clinic. These patterns of muscle weakness have been described by Barone, Robert Barone, and he's written extensively on this. I will only be discussing the first 4 patterns today, but if you see this is if you go through the 10 patterns, the most common one is the limb girdle pattern, which is most myopathies, and there's some overlap with spinal muscular atrophy. The second pattern is distal weakness, and this is predominantly seen in distal myopathies, and there is some overlap with neuropathies. Then the third pattern is proximal arm and distal leg, which is called a scapuloperoneal pattern. And this can be seen in facioscapulohumeral dystrophy, Emery-Dreifuss, and some congenital myopathies. Pattern 4 is distal arm, proximal leg, which is opposite to pattern 3. This is seen classically in inclusion body myositis and myotonic dystrophy. Pattern 5 has ptosis and ophthalmoplegia, and this is seen in adults in oculopharyngeal muscular dystrophy, in myotonic dystrophy, in mitochondrial myopathies, and then there is an overlap with neuromuscular junction disorders, such as myasthenia gravis. Pattern 6 is isolated only neck extensor weakness, so they have a head drop, and that's about it as the first presentation. And when somebody has that, you have to consider isolated neck extensor myopathy, you have to consider myasthenia, or you have to consider motor neuron disease. Pattern 7 is tongue and pharyngeal weakness or a bulbar pattern, and this is fairly straightforward. It is neuromuscular junction disorders and ALS and oculopharyngeal muscular dystrophy. Pattern 8 is episodic weakness with or without rhabdomyolysis with an associated trigger. These are seen in metabolic myopathies, like I've already mentioned, McArdle's and CPT, or can be seen in drugs and toxins. Pattern 9 is episodic weakness with the delayed, which comes on delayed, or it can be unrelated to exercise, and this is seen in primary periodic paralyses and channelopathies. And lastly, pattern 10, which is stiffness and inability to relax, and that is all your myotonic disorders, which is includes myotonic dystrophy, as well as myotonia congenital at periodic paralyses, etc. So the most early, one of the earliest descriptions and the earliest pictures were of this, and this, as we can see, this was described first by Gower. You see a boy with big calves, calf hypertrophy, and then the classic Gower sign, where they, when asked to sit on the floor, they will first extend their legs and then climb up their legs because of the proximal muscle weakness. I make all children and sometimes even adults do this in clinic because this is the most sensitive way we can tell about proximal muscle weakness. This is what characteristically limb girdle weakness looks like. This is inability to abduct their shoulders, and they have severe lumbar lordosis. Again, this is because of the weakness of the paraspinal muscle. So this is a classic stature that they have. So this is pattern 1, which is limb girdle weakness, seen both in acquired and hereditary myopathies. And hereditary may, again, it would be a long list. So most dystrophies would have this, even congenital myopathies, mitochondrial Pompe's disease, all of them can have this similar limb girdle pattern. And spinal muscular atrophy type 3 and 4, which is late onset, will also have this limb girdle pattern. And in acquired, all your myopathies will have this similar, inflammatory myopathies, endocrine myopathies will have this limb girdle pattern. The second pattern is of distal weakness, and here you see very thin legs, right? So the distal legs are very thin compared to the thighs, and it's a tapering kind of muscle loss. This is one of my patients who had, where we see that the posterior compartment is much thinner. Normally the gastroc needs to have a bulge over here. It's much thinner compared to the anterior compartment. Same is the case here. This is more diffuse thinning and tapering. And when you have a patient like this, where they have such thinning of the legs, it is very easily, one of the differentials is a neuropathy. And if they have no sensory symptoms and it's pure motor symptoms, so then your differential becomes either a distal myopathy or a distal motor neuropathy, as can be seen in distal, the whole set of distal spinal muscular atrophy or distal SMA. So that would be your differentials for very thin legs, and this is distal weakness. There's a whole group of distal muscular dystrophies. In the late onset, we have Wiellander, and Wiellander is characteristically seen with leg weakness as well as distal weakness of the finger extensors. Early adult onset mein Nonaka aa jata. Nonaka has anterior compartment, meaning tibialis anterior weakness, whereas Miyoshi and Lang have posterior compartment, meaning gastroc and soleus weakness. So Nonaka initially presents with a foot drop, whereas Myoshi presents with inability to stand on toes. The second big group of myopathies which cause distal weakness are the myofibrillar myopathies, and the spectrum is increasing day by day. Every year a new gene is described which is responsible for this group of myopathies. Myotonic dystrophy also causes distal weakness, specifically of the intrinsic in the finger extensors and flexors. Congenital myopathies can have distal weakness, and then, like I already said, there is an overlap with neuropathies whenever we're considering distal predominant weakness. The third pattern is what we see here, and I wish I could quiz you guys on this, but what we see here is bilateral scapular winging, and the scapular winging happens because of loss of all the periscapular muscles. Here, the patient is trying to abduct their shoulders, and because the trapezius is gone and all the periscapular muscles is gone, this is actually the scapula, the top of the scapula jutting out from the skin. So this is very characteristically, this is periscapular muscle loss, but here you see that the deltoid is relatively spared. Here we see humeral loss, humeral muscle weakness. So the, biceps and triceps are severely atrophic. The deltoid is a little spared. Along with this scapular humeral pattern of muscle loss or weakness, you can also have facial weakness. In this patient who had also had scapular winging, here he is trying to blow air into his cheeks and not able to do so. This is the best he can do. Here in the second picture, he's trying to close his eyes real tight, but that's the maximum he can do. So he has facial weakness too. This is a family of siblings, all of whom, as you can clearly see, have facial weakness. They are very thin built, very thin muscle mass. Both the elder ones are trying to smile, but this is the maximum they can do. Both of them have ptosis. The youngest one is unable to open his eyes because of the ptosis and has a fish mouth abnormality because of the weakness of the perioral muscles. They have a type of congenital myopathy, which is resulting in such less muscle mass and weakness of the face. Also, always look inside the mouth. You're looking at the tongue and you're looking at the palate. So a high arched palate is again pointing towards a congenital myopathy, because that means that even in utero, there was weakness of the muscles that resulted in the palate developing the way it did. So this is a high arched palate. So this is pattern 3. This was pattern 3. There can be proximal arm and distal leg weakness, which is scapuloperoneal. And the scapuloperoneal pattern is seen in scapuloperoneal myopathy, Emery-Dreifuss, humeroperoneal dystrophy, and Emery-Dreifuss में एक additional चीज होती है of early contractures, so that can help you with the diagnosis, and it's X-linked. Pompe's disease can have a scapuloperoneal pattern, and congenital myopathy, like the children I just showed you, can have this scapuloperoneal pattern. If it is associated with facial weakness, then it's most commonly, most likely to be a facioscapulohumeral muscular dystrophy, like the first patient with the scapular winging. The fourth pattern is distal arm, proximal leg, and this is seen in inclusion body myositis, myotonic dystrophy. And commonly they have finger and wrist flexor weakness and quads weakness, so the knee extensor weakness, and it is very commonly asymmetric. Okay, this is pattern 4. This is either inclusion body myositis or myotonic dystrophy, depending on whether you're thinking it's acquired or hereditary based on your history. Just a few more pictures of what else you can see. Now, this is an adult with huge calves, big calves, right? Calf hypertrophy. So it's an adult, so I'm not thinking that he has Duchenne's or Becker's because he's a little old, but this can be seen in other limb girdle muscular dystrophies, particularly sarcoglycanopathies. It can be seen in limb girdle muscular dystrophy 2I. It can be seen in FKRP, fukutin-related protein mutation, okay? Or it can be seen in metabolic storage disorders. This picture is signifying asymmetry. There's a very clear asymmetry. If you look at the humeral muscles here and the humeral muscles here, this is much thinner. The left side is much thinner compared to the right side. Similarly, in the leg, actually the right thigh is thinner than the left thigh. One additional thing I would like you to do here, notice is that I have asked him to flex his elbow, and when he flexes his elbow, this bulge comes out, and this is called the biceps bulge. And this is clinically, this patient has limb girdle muscular dystrophy type 2B or a dysferlinopathy. And dysferlinopathy characteristically presents with asymmetry of weakness, presents with this biceps bulge, presents with also posterior compartment weakness, can have very high CPK levels, and can even have inflammation on biopsy, confusing it with an inflammatory myopathy. This is what we call the Bethlehem sign. This child is, I always ask them to do, at the end of my examination, I ask them to do this. And when they try to bring their hands together, they're unable to extend their distal fingers. This is because of contractions, flexion contractures in the interphalangeal joints. And this is called the Bethlehem sign. Characteristically seen in myopathies that cause contractures, particularly the collagen 6 dystrophies, Ulrich dystrophy and Bethlehem dystrophy, or Emery-Dreifuss. But most commonly, this child had a collagen 6 mutation and was diagnosed with an Ulrich myopathy. Similarly, the same patients, in addition to having distal contractures, have hyperextensibility, hyperflexibility. So both these patients, you see, I asked them to put their fingers down, and this is how flexible they are. You should try this at home. I'm sure none of you should be able to do it. If you are, then I think we need some genetic testing. But this is a sign of hyperflexibility. And again, this is seen in the collagen 6 dystrophies. Always look at the spine. This shows a scoliosis, and this I'm asking him to bend down and touch his toes, but this is the maximum he can do because he has a very rigid spine, and he was later diagnosed as having a selenoprotein mutation, SEPN1 mutation. So there's a whole group of rigid spine syndrome or rigid spine dystrophies. This is a case where she has asymmetric hypertrophy, and even if you see on the MRI, the right leg has really big muscles compared to the left side, but there is no inflammation. So in the post-contrast, there's not much inflammation in the muscle. And she had a very interesting finding. I'm going to play the video, please. That's it. Okay. Anyway, she had rippling of her muscle, and it was actually the rippling of the muscle which had caused her muscle to be so big. Unfortunately, I can't play it. I don't know what happened. So, and we did all the other genetic tests on her. Everything we did, everything was negative. It was isolated rippling of one muscle, and we treated her with initially with mexiletine and later with phenytoin. And once we got the rippling under control, her muscle mass started coming down. So the bottom line is, on the basis of your history and exam, if there is fixed weakness, you need to look for a pattern. If there is episodic weakness, you look for triggers. If there is stiffness or myotonia, look for triggers and location, associated weakness, and other features. If somebody is coming with pain and fatigue, which is constant, present all day, you don't find any weakness on your examination, reflexes are normal, you know, some of your ancillary tests are normal, it usually won't be a myopathy, and it will end up in the category of fibromyalgia or myalgia. So they usually don't have a muscle disease. Just 2 slides I have on diagnostic testing. If you have considered आपने history ले ली, examination किया है, you're thinking, okay, this is muscle. First thing you're going to, you've isolated it to the muscle, and you've also thought about whether you're thinking about an acquired or hereditary disorder. Start with the serum creatinine kinase and do your basic electrolytes, thyroid functions. If ye bade mein hai, now you're clearly thinking, if you're thinking an acquired disorder, the first step always, you need an EMG NCS to document the myopathy and to document whether it's an irritable or non-irritable myopathy. The second thing is, if you're thinking this is acquired myopathy, it was an acute or subacute onset, send out an entire autoimmune workup, including myositis antibodies, which includes anti-Jo1, anti-Re, anti-Ma antibodies. Okay. Muscle biopsy, I think I'm going more and more away from doing muscle biopsies, and so is the trend now in the US with such specific antibodies now available and genetic testing available. Muscle biopsy, it's still used when we really confuse as to what's going on. Genetic testing and then other ancillary tests are urine for myoglobin, ischemic forearm test, and muscle imaging can really help you identify if there's inflammation, if there's dystrophy, if there's muscle mass. Treatment is going to be obviously disease specific. If it's a hereditary disorder, the only hereditary disorder that you can treat is Pompe's disease with enzyme replacement. The rest require supportive care with physical therapy, assisted devices, symptomatic treatment. The most important, extremely most important thing in these hereditary disorders is counseling. Counseling of the families, counseling of the patients, that they need lifelong rehab so that they are able to maintain a certain kind of quality of life. And for acquired, depending on the cause, you will think about immunosuppressive or immunomodulating treatment. And with that, I am going to end and hand over to Dr. Sajjad.
Thank you, Dr. Sara, for a very informative talk about myopathy. We'll quickly move on to the third and the last talk of today's session, which is nerve conduction studies in polyneuropathy and myopathy, because we are running a little behind time. For this, I would like to invite Dr. Sajjad Ali. He's working as a consultant in clinical neurophysiology section at National Institute of Neurosciences, King Fahd Medical City, Riyadh. He will be covering a very important aspect of neuromuscular disorders. So Dr. Sajjad Ali, kindly you can share your screen now.
So everybody can see the slides. Thank you so much for the opportunity to present on this forum. I think this is one of the many more similar sessions and collaborations to come forward. So what I'm going to be covering, I think both Ehtesham and Sara have done me a huge favor by sort of going through all the clinical aspects. So I would be concentrating more on the electrodiagnostic aspects and giving some basics as well as approach to polyneuropathy and myopathy. So we'll go through some basics about approach and look at some basic techniques of what we do with nerve conduction studies. And then we will look at criteria for polyneuropathy and approach as well as myopathy. So we've already gone through a list of peripheral nerve disorders, both neuropathic and myopathic. And one of the main aims of any neurological encounter, and especially nerve conduction, is localization. So we want to know where the lesion is. And most of the time we're trying to sort of fit in using these as tools to see if it is a neuropathic process, is a myopathic process, or is related to a neuromuscular junction. And a lot of times we may be excluding these disorders because there may be some other etiology going on. So whenever we see a patient for nerve conduction study, the patient may has already seen a clinician, but we still have to do a brief history and directed physical examination to formulate a differential diagnosis so we can plan our study accordingly. And we need to explain the test to the patient, assure them that there's no harm going to come out of this. More importantly is that whenever we plan a nerve conduction study, we should be interpreting the results as they come along, because a lot of times you may see results or interpretations that are new to your differential diagnosis, and you may need to modify your nerve conduction studies as well as your EMG. So you may need to add more nerves or more muscles when you're looking at that. So that is very important, that to look at this as a dynamic study, to be able to interpret the results as you go along and modify your study accordingly, so that you can reach your end result with a better differential diagnosis. So the cardinal rules of nerve conduction remain the same, that it's an extension of your clinical examination. And more importantly, in fact, most importantly, is this bit over here, which is that, you know, your electrodiagnostic findings is a correlate to the clinical problem. And whenever you think that there is a doubt, you can always sort of, you know, think about technical factors. Sometimes you may re-examine the patient and find a clinical correlate of your finding. And that is very important, because end of the day, this is what matters, is the clinical and electrophysiological correlation. Whenever you're in doubt, you try to repeat the test. You do not overcall a diagnosis. You don't want to do a type 1 error where you put a label on a patient which may be harmful later on, and will have the patient go through a lot of other tests. But it's important to have this clinical correlation all the time. So just going through a bit of basics, and I'm trying to sort of recognize a sort of pattern recognition and some concept building. I'm not going to go into much technicalities, but when we're doing motor conduction studies, there's always a question to start with motor first or senses first. It's entirely how you're trained to do things. It depends on that, what your choice is. But some considerations is that if motor nerves are easily located, recorded, because they are bigger responses, they are not contaminated easily, they are reported in millivolts as compared to sensory responses. So sometimes it's easy to do motor because you get them easily and they're easily recordable. But you need a bit of higher stimulation. So if you have an apprehensive patient who you may think that you start with motor will become a bit, you know, may not let you complete the study, then doing sensory first may be easier, maybe more rational. So it depends on how your patient is, and it depends on how you're trained to do things, but there is no hard and fast rules as such. When we record motor studies by placing the active electrode, you can see on the video here where my mouse is on the muscle and the reference on the tendon. And what you're recording is the differential, your differential amplifier records is the potential difference between the 2 points after you have stimulated the nerve with the electrical impulse. So you stimulate the nerve with an electrical pulse, which then propagates down which then at that point, there's a small field here, which is few millimeter enough to initiate a nerve action potential, which then propagates down to the terminal axon, causes release of visceral contact, causes post-synaptic depolarization if it reaches threshold, and then you get a muscle fibers contracting and you get a muscle twitch. So what you record at the end is this sort of a waveform, which we call the compound muscle action potential, or the CMAP, which basically the height of this is what we call the amplitude, and it represents the number of axons that we have stimulated in the nerve over here. So although we are recording a muscle response, it is indicating the response of the nerves that have been stimulated. And we see that there is a latent period before we sort of get the response. And this latent period is the time that the pulse gets to travel from the stimulation point to the recording electrode, and we call this latency. And as you can see, we are recording myelinated nerves basically. When we're doing nerve conduction studies, we can only assess myelinated nerve fibers. And this latency is dependent on this sort of myelin and the gaps between the myelin, which we call the node of Zennwehr. And we know from our basic physiology that this is saltatory conduction and this is fast conducting fibers. So we can know that this time period, which we call the latency, is the function of the myelin, which we record in the nerve. Whereas the number of axons that have been stimulated is the height or the amplitude represented there. Where the waveform sort of leaves the baseline and returns to baseline is the duration, which I'll come to a bit later. But in motor studies, one thing is important is that we do supramax stimulation. And this supramax stimulation sort of where you keep stimulating until you see that the see map amplitude is not going any further, and you increase your stimulus to 20% more. And the reason is that you want all your axons to be stimulated. This is just few recordings of, this is a distal recording at the this wrist, and then the proximal recording at elbow. And you don't want, you want to calculate a conduction velocity between the two nerve points. You don't want the neuromuscular junction and the muscle bit in it. So that is why you sort of want, you don't want this section of the recording to be part of the nerve conduction velocity. So you choose 2 points where it's only nerve, and you are like removing the latency which was involving the neuromuscular junction, the muscle. So here what you get ultimately is the distal latency and the other second latency, which is the proximal latency, and the machine calculates the difference. You calculate the, you measure the distance, and distance divided by this latency difference gives you the conduction velocity. And again, you can imagine that this conduction velocity is dependent on the myelin, and it's a myelin function. So these are the important parameters. You look at the distal latency here, the amplitude, which is in millivolts in motor studies, and the conduction velocity. So these are the 3 parameters mainly that you look at. Coming to the duration part, what you can see over here is the where the waveform leaves and then returns back to the baseline. So let me explain this a bit. You see this picture here, you see all the horses arriving at the same time. So basically the duration is telling us the synchrony with which the pulses arrive under the electrode. So if they're all arriving at the same time, you get a nice smooth response, and your duration is like in motors is around 2 to 5 millisecond, and sensory is 1 to 2 millisecond. Whereas you see in the second picture, the horses arriving at different times. So if I plot a graph of their arrival times, I see that the plot is sort of spread out. So we say that it is sort of dispersed, and it is dispersed in time. So this is what we call temporal dispersion. Just look at it in a bit more detail over here. You see this stimulation at 2 points. We see nice smooth sort of responses, both distal and proximal. But when we look at over here in the distal stimulation, we see that most of the myelin here is intact, except this last bit over here, but still we get a nice response. But when we look at the second stimulation, we see this patchy demyelination here, 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 and big chunk of myelin gone there. And now what happens is that these these nerve fibers arrive at different times, and we see that it's all spread out. So 2 things are happening over here. One is that the amplitude drops, and the other is it spreads out. If we look into it in more detail, we see that there is amplitude drop, and then we also consider one more thing, which is the area under this curve. And we call it the area by its name. And we see that the height is the amplitude. So we need to consider if there is loss of area, just not the height, for it to be a true conduction block. So I'm just going to explain this a bit further in the next slide. You can see the amplitude has dropped, but we don't know if the area has been dropped. So the area we cannot calculate manually. The machine has a software to do that, and it tells us if you have ticked that option on for in your system. So if you look at this example where you have 3 apartment buildings, each 1,000 square feet. So the total area over here is 3,000 square feet. So I can build the same apartment on top of each other, and here also the area is the same, 3,000 square feet. But for me to have a true conduction block, what I need is a drop in the height or the amplitude of more than 50 or 50%, as well as drop in area. So if I have a true conduction block, I have to really get rid of just not the height, but also of the area. And that would be a conduction block. Now, you can imagine that the arrival of the response in the previous slides was delayed at different times. It was dispersed. And again, that was because of the myelin dysfunction. So to summarize, if we look at the axon and we look at the myelin, what are the modalities that help us decide which is the myelin function and what are the axonal functions? So myelin function, we said, is represented by the latency. And for it to be in the myelinating range, you really have to have very prolonged latencies, and go to exact criteria later on. But when we look at the conduction velocities, it's inversely proportional. When you're taking more time, you're more slower. So that is why your conduction velocities are also very slow. And then the third criteria or the third function is the duration, which is marked by temporal dispersion and conduction of that we just saw on the last slides. And when we come back to the axonal function, most of them is the drop in the height or the amplitude, if it is the CMAP in the motor nerves and the SNAP in the sensory nerves. So if we have this sort of concepts, we will always be very easy for us to determine when we are looking at the data or the waveforms, we can differentiate how the demyelinating criteria are sort of taken into account and what are the axonal criteria. Another thing that we usually do is the FA, which is, I'm not going to detail of that, but also that is the function of the myelin because it's a latency. It shows how fast the FA return back to the recording electrode. So again, this will be very much prolonged. So these are the essential sort of core concepts that you need to build when you're approaching nerve conduction studies. Sensory studies are easier to do, are more simpler. There's no neuromuscular junction and muscle there. You stimulate at one end of the nerve and record at the other end. The parameters are the same amplitude representing the axon, the latencies, and the conduction velocity representing the myelin. We do sensory conduction studies two ways. One is antidromic, where you sort of stimulate the nerve opposite to the normal sensory pathway. So you're stimulating at the wrist, whereas the sensory conduction or the sensory pathway takes the sensation from the periphery to the center. So you are stimulating sort of on the wrong way, basically. Whereas in orthodromic sort of stimulation, you plug the same ring electrodes into the stimulator and you stimulate the sensory nerve, which travels across with the same direction of the sensory pathway, and that is orthodromic. You can do either one of them. It depends on which one you've trained. They have their own normative data to compare with. Important thing to realize is that when you do recording antidromic, you get bigger amplitudes. You see over here 33 microvolts. Because when you're antidromic, you are recording from the tip of the finger and the nerve is just below the digital branch of the median nerve here. It's just below the skin. So you don't have much of sort of distance between the recording electrode and the nerve. So you're very near to the nerve. But when you record an orthodromic response, placing the electrodes on the wrist, the nerve is a bit deep down and there are tendon and fascia, and that's why the amplitude sort of, you're not near the nerve and you record a smaller amplitude. So it's more like a technical reason, otherwise it doesn't matter basically. So it depends, you can do either one of them, whichever you're trained to do better. Examples of just some waveforms. Again, you look at the latencies, you look at the onset latency. Now we have one more latency we call the peak latency. Usually you can use this if your onset is not very clear, and usually you use this to compare side-to-side comparisons, or you use to compare ulnar or median sort of in carpal tunnel. So whenever you're doing a comparison between one or two nerves or side-to-side, peak latencies are useful. This is again the amplitude and the conduction velocity. The reason I'm highlighting these circles is because different machines have different presentations, but just to show you, if you know that where is millisecond is the latency, where is millivolt or microvolt is the amplitude, and then meter per second is velocity. You can easily see that in a table, it may be or on the machine waveform. So when we have a patient with neuropathy, we've already looked at the clinical side, but the questions that we want answered from your nerve conduction study is to see what is the fiber involvement. Ehtesham clearly showed you the differential that would depend on the basis of the fibers involved. And most importantly, you're trying to decide if this is an axonal process, is it demyelinating, is it acquired, or is it inherited? And a lot of times when you're looking at disorders, you can, with these findings, you can also determine the temporal course based on the nerve conduction findings. So looking at the top diagram, which is a couple of waveforms from median stimulation, shows normal pattern. You look at the second, you see a significant drop in the height of the amplitudes or the amplitudes in the height of the waveforms, whereas you see that more or less the distal latency and the conduction velocity are still well preserved. So if you look at the drop off of typical conduction velocities, it's a random dropout. So whenever there is axonal loss, some fast fibers and slow fibers both drop out randomly. You still have fast fibers to give you a normal conduction. So you really have to have significant axonal loss where your conduction velocity will be affected, and that usually happens later on in the process where it's quite severe. Looking at C, now the third set of waveforms, you see that both the waveforms are delayed, but you don't see, you still see a smooth waveform, which shows that here the latency is around 12.7 millisecond and a very slow conduction velocity of 12. So this is clearly showing that the myelin is a problem, and this is very diffuse sort of myelin problem, because if you compare this with the last one, you do not see, you see the temporal dispersed waveform, which is the second one. If you recall that that slide where we showed patchy denervation, which means that this is an acquired process, because usually whenever there is demyelination in a patchy form, it is acquired. But if there is a demyelinating problem, which has been right from the start or in utero, then you know it's an hereditary problem. So based on temporal dispersion, you can determine, or you can differentiate if it is a hereditary neuropathy or if it's an acquired neuropathy such as GBS or CIDP or whatever. So these are the most sort of common patterns that you want to know, and this is the information that you would want to put in your report so that your further diagnosis is helped for your clinicians. When you come to criteria for axonal peripheral neuropathy, there is a significant drop, just to recap, in the CMAPs as well as the SNAPs. Now, most of the time, whenever there is mild to moderate neuropathy, sensory responses are in microvolts. They're easily affected and early on affected, so they may be absent, and you may see low CMAPs. Now, usually we say that if you're seeing a patient with GPS, do nerve conduction around 8 days to 10 days. But in severe cases, a lot of time I've seen if the patient is weak and is like weakness is not ambulatory, it is that weak, usually you see drop in CMAPs even on day 3, day 4, especially when you're dealing with severe axonal forms like AMAN version of GBS. Latencies may be borderline prolonged or normal. And as you said, conduction velocity, because even if a few fast conductive fibers are intact, you may still get normal conduction velocities. When we look at the demyelinating criteria, we see that the CMAPs may be affected borderline or mildly, but SNAPs go on early on. And most of the patients you come with, even with, they come early on, you may see that SNAPs are gone again because they're vulnerable, or if they're still preserved, they'll be very low. Latencies are prolonged, and we say that they're prolonged by 130% of upper limit of normal. Easy way to remember this is that if your motor median latency is 4.0 millisecond and you take 130% of that, that becomes 5.3. So when you look at upper limb latencies more than 5 to 6, you just keep that sort of a number in your mind, and you know that this now you're dealing with something which is really demyelinating. So if you have a conduction latency of 4.7 or 4.5, it is prolonged, but that may be not a primarily demyelinating problem. And so not every borderline or mildly prolonged latency is a demyelinating feature, and that is very important thing to remember. Similarly goes with conduction velocities. They have to be low, but they have to be really low. So if your if your one number to remember for upper limb conduction velocities, if it is 50, then you're looking at around below 30, 35 easily. These are in demyelinating range. So if you have these gross numbers in mind, you can just look at a waveform or the data and easily tell this is demyelinating or axonal. And for the latency, the same values for the FF latency. You add conduction block and temporal dispersion as discussed earlier. This becomes fulfills criteria for acquired. The rest of the demyelinating criteria is the same. Going on to approach for myopathy, the information that you can gain from EMG and nerve conduction, you can tell the distribution. Obviously, you have already examined clinically, but you just want to confirm, and you need to choose your muscles accordingly to a clinical picture. You need to see which are the weak muscles. You don't do those muscles which are totally sort of, there's zero power in it because they are totally burned out. You may not see much pathology there. Importantly over here, which I want to, so you want to look if there is active denervation on spontaneous activity. If there is none, then we call it bland myopathy, or if there is active denervation, we call it, those which are inflammatory myopathies. I'll just go into more detail of that. And if you this presence of myotonic discharges, and again about the course. So when you do nerve conduction in myopathy, you want to do routinely at least a couple of nerves. Just to mention for my polyneuropathy protocol, what I usually do is I do both lower limbs to see symmetry, and at least I do one upper limb. So you can do a couple of sensory nerves, superficial, peroneal, sural in the lower limbs, and tibial and peroneals in lower limbs, and I do median ulnar in the upper limb. But I also do a radial sensory as well, because radial sensory is one of the nerves that is quite late involved, and to determine if it is a length dependent process, you're going to see that sort of variation. So that is why radial sensory is important. Coming to nerve conduction, you expect them to be normal, but if you have advanced myopathy where your muscle is atrophied, your CMS may be a bit on the lower side. You usually want to do one motor sensory with F5 in the upper limb and one in the motor sensory in the lower limb. It's entirely your choice which ones you want to do. But in myopathy, you need to consider with your some special considerations. So if you have low CMAPs at baseline, you want to do a simple exercise of 10-second maximum exercise to see an incremental response, to see if there's underlying presynaptic problem going on. And whenever you have normal nerve conduction studies or EMG and you still have proximal weakness or there is fatigability, you want to do RMS. So these are just some special considerations that you may consider in myopathy. Regarding the EMG, as Sara already said, we need to confirm the distribution and the diagnosis. You do routine EMG, at least 2 proximal muscles in the upper limb and 2 distal, and the same in the lower limb, and at least paraspinal. I'm not a very huge fan of paraspinal. If I see very good myopathic changes, I usually leave out, but sometimes it is requested because some myopathies affect axial muscles more, and that depends again on the clinical picture. Special considerations that always consider weak muscles, not totally burned out muscles. Consider long flexors in the arm when you're considering inclusion body, because that would be clearly showing more involvement. And also, if your clinician, sometimes they may be asking that, which muscles we should biopsy. So do some muscles, although as Sarah said, biopsy is becoming obsolete now. But again, you should consider muscles that are easily accessible for biopsy. And sometimes your myopathic changes, especially with chronic myopathies, their secondary denervating changes. You may not have a very clear picture. If you're not very confident with your myopathic results, you can always do a bit of more quantitative MUP analysis, which sort of gives you a bit of quantitative data to go to one side. This is clearly myopathy or not, and where indicated, you may use single fiber EMG as well. Now, active denervation, when we are doing EMG, we see fibrillation potential, we see positive sharp waves. It's very, very important to know. Now, you may think, why do you get active denervation in a myopathic process? Because the nerve is intact. Well, it's very important to know that whenever you're having these processes, there is segmental inflammation, necrosis, there's fiber splitting. And what happens is that this sort of part of the muscle fiber becomes sometimes even detached. So it becomes sort of, there is no nerve supply going to it. So it acts like a denervated muscle fiber, and that is why you start to get fibrillation potential on there. So wherever you have muscle necrosis, inflammation, and this is the group of sort of myopathies, I've not gone the details already, Sara has gone through, that where you will be getting active denervation. And it's very important, one of the important findings that you want to document in EMG. So this is what happens when you look at the morphology of the motor unit. When you activate the muscle, you see recording. So this is a normal motor unit. But when you see in myopathy, you see that there is some thin fibers, some hypertrophic fibers, some split fibers. So there is a fiber variation, there's fiber diameter variation. And this is what causes polyphasia in your EMG. So what happens is that there's loss of muscle fiber, your motor unit has become smaller in amplitude, and your motor unit potential, and shorter in duration. You can see over here, normal distribution of motor units. In myopathic, they become less motor units, and there's loss of muscle fiber, a bit of clustering. And what you see when you look at the motor unit potentials are very spiky, small, short duration potentials. And I'll just show you some videos to grasp this better. So first of all, in spontaneous EMG, you look if there's any denervation or not. And also you look for myotonic discharges, which, because your differential will be very helpful in that. Secondly, you look at the morphology of the motor unit, and then you look at when you activate how that's the recruitment, sort of the recruitment pattern, how do motor units fire. So just showing you what normal recruitment looks like when you have a full pattern. So you start to activate one motor unit firing, few more firing now. And as you're recruiting, they're following the normal principle of recruitment, that as you increase, more motor units add, and ultimately on full power stimulation activation, you see that the whole motor units are interfering with each other, and you see a full interference pattern. And you see that the envelope of the whole your EMG response was increasing. And you can also look at the sound, how the sound is. When you go, we look at a myopathic pattern. What happens is very typical. This is Becker's muscular dystrophy patient. And important thing is that over here, you see that they had mentioned that this was minimal contraction. This is the key for EMG myopathy, that you stimulate, you activate the muscle with very, very little effort. And you won't know that until you place your hand on your, the other hand on the muscle or the arm where you're activating. So give a bit of resistance and ask them. Sometimes you even say that you think that they're activating the muscle. And even that, you see that all the motor units, because the muscle fibers are weak, all motor units start to fire all together. So just here you see many motor units firing together. It's a very scratchy sound, high-pitched sound. Oops, sorry. If I just pause over here, you may see this is a bit, if you look at this motor unit, you see it's very spiky, very thin, very small. You may say there a bit of polyphasia, and there is of increased duration. So you will always have mixed pattern in myopathy, but what you need to do, pause your EMG and look in between for these spiky small ones, okay? And the amplitude also shows that they are small. So you don't just look at one aspect, you look at the whole picture and try to fit up the pattern. So it's more like pattern recognition rather than seeing that this is polyphasia, is it neuropathic change? No, the amplitude doesn't go with that. And in between, you see these small spiky ones, then they give it away basically. Again, you may say this is polyphasia, but then you see these small ones in between, very spiky, and they give it away. The sound is very important, very scratchy, and the recruitment is early, that little effort, and you see a full screen. Another example where the amplitude sometimes can be misleading. This is hypertrophied muscle fibers seen in explosion body myositis. And please note the gain over here is 1 millivolt. So here some of these are like 4 to 5 millivolts, and you will say that this is very high amplitude. And but if you look at in between, again, as I said, you pause it in between, you see this small, very thin 5 potential, one very thin potential, and this gives away that this is a myopathic process. You don't get fooled by a few of the higher amplitudes. And you don't call it neuropathic. And obviously with very little activation, you see a full pattern going on, the early recruitment pattern. And again, the sound is very scratchy over here as well. So a summary that EMG helps you localization. If you have your myotonia, myotonic discharges, this is the whole differential that you're looking at. And if you have denervation, a long list of differential over there. You want to also consider other disorders that mimic myopathy, and sometimes you may use EMG to assess response to therapy. If you're interested in biopsy, it can give you that information as well. So to summarize, always when you do nerve conduction studies, the most important thing is it's like clinical electrophysiological correlation, and always do it like a dynamic study. Look at the test results before the patient leaves, and you may add more nerves or muscles to do. Nerve conduction studies are techniques which are very standardized. They need expertise, and it's always good to have normative data from your own lab. I think Sara has already published on normative data from Pakistan. So I would really recommend that use your own population normative data. It's already published. And I think that's fantastic for you to have for the Pakistani population. I like to have protocols, but always protocols are so that you don't miss things, but you should not be very stringent with protocols. Always keep in mind when you're approaching polyneuropathy, what are the demonitoring criteria, and the axonal. I hope I have nailed those today, and I've just built concepts. And don't try to remember numbers, try to remember the concept. What is the function of, what function is the myelin, what function is the axon. And in myopathy, always assess weak muscles, look for active degeneration. The morphology is very, very sometimes misleading, so the recruitment then helps. So I think that's the last slide that I have, and thank you so much.
Thank you, Dr. Sajjad. So we come to the question and answer session now. I have a few questions in the chat box. First, I would like Dr. Ahmed Wali has a question for Dr. Ehtesham, first of all. So Dr. Ahmed Wali, you can unmute yourself, ask your question.
Okay, thank you very much, Dr. Ayesha. First of all, I want to congratulate all of you, especially Dr. Ayesha, Dr. Sara Khan, Dr. Ehtesham, for arranging such wonderful session, and especially to Dr. Ehtesham for his wonderful and comprehensive yet precise presentation. So my question is that sometimes we see very variable response to different brands of IVIG, especially when we are treating AIDP or CIDP. Since we neither have IVIG in our government hospitals nor insurance system in Pakistan, so families of the patients arrange that IVIG which is easily available or the cheaper one. And of course, being in desperate condition, most of the time we cannot argue with them, and the result is of the treatment is unknown. So what is your experience in regards to different brands of the IVIG?
Okay, that's a very good question, Ahmed, because there are a couple of brands available. There is what common one, Gamunex, which we were using in the US. There is another one called Gemagard, but there are a couple of others as well, and there is a variability of response. It's not only with respect to the IVIG, the immunoglobulin part, but it is the vehicle used in it. So that's why there is a sometimes difference of response between different patients based on the formulation used. So the general thinking is that if we use one brand, we should try to stick to that brand and not try to play between different brands. I always tell my patients, say that try to pick the good one, not the cheap one. So if you're already spending a couple of lakhs, spending a few extra thousands may not make a big difference. So that's what I usually tell them. And thank you very much for your kind words.
I think you had a comment to make as well, Dr. Ahmed.
Yeah, of course. So I think as a PSN body, we need recommendations from different neuromuscular specialists to regularize or to make guidelines for the proper indication, source of IVIG or specific brands in order to provide maximum benefits to the patients. So this is what I request, and for this, after this making neuromuscular section, I think we should work on this because patients and their families are lurking in the dark, especially when they have to deal with IVIG.
Inshallah, I think as we have already established the group, with the help of the colleagues and the seniors, we will be able to streamline it more in future, inshallah. We'll look forward to work on it.
Next, I think there's Dr. Bashir Somro has a question to ask. Sir, can you unmute yourself and then you may ask your question straight away. Dr. Bashir Somro. Maybe he has left. He had a question to ask, so we can.
This question is in the comment in the chat box. I can read it out.
Okay.
Sometimes we see a lot of patients come with pain and are doing needle examination. Few muscles show myopathic patterns, while few show neuropathic patterns, and the NC is normal. And then where we go? I think I will again say it's a clinical correlation. I think what Sara and Ehtesham has already emphasized is the clinical approach. So if you have your clinical correlation there, sometimes you may, even in normal people, see some high duration motor units which look neuropathic, which I think are meaningless. So if you don't, if it all depends what your clinical differential diagnosis is, and that will guide your EMG findings. Otherwise, EMG findings are just sort of, numbers without that clinical correlation. So I think it's very important to be guided clinically and to consider your EMG findings accordingly.
Okay.
Ayesha, there are some people in the audience asked this question with respect to why nerve conduction study or EMG was not mentioned in a polyneuropathy presentation. So I mentioned ancillary testing, and I should have been more elaborative about that. That ancillary testing means nerve conduction study EMG or electrophysiological testing. I didn't go into the details of that because I already knew that Sajjad gonna present it. So I was more focusing on the approach and laboratory testing for the etiological assessment of polyneuropathy. But that is part of ancillary testing for polyneuropathy patients.
I hope that answers the question. If we have any other questions, the attendees want to ask any question, they can just unmute themselves and then directly ask the question.
Ayesha, I have one comment for Dr. Sara Khan. In the era of this COVID-19, we have seen, especially I have seen 3 patients, young male, when they were post-COVID and they came in to my clinic with severe backache and severe muscle spasm, or clinically you can say myalgias. So when I took the history, they were experiencing this for the last 3 to 5 days. And we did all workup that was negative, except for this CPK that was borderlinely elevated, that was from 100 to 300. So I think we should make a research, or we should do research on note all these patients which come after COVID with severe myalgias and back pain, and especially that pain was in the upper back and the lower back. And we just treated them conservatively, and they were then became normal. So what was your experience? Have you ever seen such patients after COVID with severe upper or lower back pain with minimal raised CPK level?
So great question, Ahmed. One thing would be rather than, I would consider root involvement much more in this. For example, in GBS, when you start, it always starts with back pain. So with such severe back pain and marginally elevated CPK, myopathy would be a little lower down on my list. Maybe they have root inflammation or GBS-like variant. However, even if it is muscle involvement, I haven't experienced it yet. I have seen COVID-related inflammatory myopathy and post-COVID myopathies. I mean, I'd agree with you. There's nothing much to do but conservative measures if this is a post-viral syndrome or a post-viral myositis. But a marginally elevated CPK, I would probably not put it in the myositis category. We are seeing a lot of COVID myositis. However, in the limited number of patients that we do have, it is very difficult to ascertain whether it is viral induced myositis or whether it's critical illness myopathy, because these are mostly inpatients and most of them have been very sick. And by the time we are called for neuromuscular evaluation, we're not really sure whether it's COVID myositis or it's critical illness.
That's right, but I'm talking about young.
Right.
Patients, they were not at home, they were not cases of COVID-19, but they had severe pain, and especially upper and lower back, not other limbs or no any proximal type of weakness. It was just relieved within 2 weeks.
Right. So with just back pain, I would think much more root rather than muscle. With such proximal back pain, I would think root, a radiculopathy, not radiculopathy, a radiculitis more than muscle.
Thank you.
And it could easily be post-viral. We've seen one case of a post-COVID radiculitis, and that was a lumbosacral radiculitis, and they had also come with excruciating back pain, but they had radiating symptoms in the legs too. and ultimately the MRI clinched the diagnosis.
Thank you, Dr. Sara. I think we have no more questions. So before we conclude, I would request Professor Ehtesham Khalid to kindly give a few concluding remarks before the end of session.
Thank you very much, Dr. Ayesha. It was a very nice session. Congratulations to Dr. Ehtesham, who has worked very hard, Dr. Sara Khan, Dr. Sajjad. You know, it makes difference when a specialized person talk about certain topics. They justified, although the talks were simple, but they covered everything. And anybody as a general neurologist who follow these presentation is unlikely to miss the diagnosis related to neuromuscular disorders or neuropathy and muscular disorders. So congratulations to all. Just to add few things, Dr. Ahmed Ali asked about IV, IgG, but I think we are a poor country and we should think more of plasmapheresis. As my experience in Mayo Hospital, Lahore, we have done more than 5,000 plasmapheresis. And if you compare the cost, we saved several hundred million, and most of the patients, they survived, results are very good. And you can save money, you can save economical burden on the country and female patient and family. Yes, there are exceptions like children and elderly people where there may be some contraindication. So I think we should talk more about plasmapheresis. It costs less. So thank you once again. And the other question Dr. Ahmed Wali asked is about the COVID. We had experience of dengue with involvement of nervous system, and many patients presented either with radiculitis or temporary myositis, which actually with CPK of several thousand, which actually were relieved. So most of these viral illnesses, they do cause these problems, and I think it needs complete workup. So again, a very nice presentation. Congratulations to all speakers and Dr. Ayesha moderating this session excellently. So thank you very much.
Thank you, sir. It's always a pleasure listening to your comments. So here we come to the conclusion of today's session. I would like to thank everyone for joining us, especially on the weekend. I would like to thank this excellent speakers, Dr. Sajjad Ali, all the way from Saudi Arabia, Dr. Sara Khan, and Dr. Ehtesham for the wonderful presentations. I would also like to thank Dr. Nasrullah and Dr. Danish for assisting me in the technical issues. Hope the junior colleagues have learned well from today's session. And if you still have any questions, you can ask, directly mail the speakers later on as well. So this was recorded. Hopefully we'll have the recorded version available as well. Thank you, everyone.
Thank you very much. Hafiz.
Thank you.
Thank you.
Assalamu alaikum.
Assalamu alaikum.